Thank you to all of you attending today's ERA-EDTA seminar. And good afternoon, good morning, or late night from wherever you are watching us. Today, we discuss new pharmacological therapies to slow the progression of diabetic kidney disease. I'm moderating this e-seminar this time. My name is Christoph Wanner. I'm a nephrologist of the University of Würzburg in Germany and currently function as the president of the ERA-EDTA. And today, the guidelines we are talking are coming from KDIGO. They are brand new, actually published in October. They are open access in Kidney International and also accepted and published in Annals of Internal Medicine. The ERA-EDTA is really proud to help to disseminate the new information, the guidance and guidelines, which is KDIGO, Kidney Disease Improving Global Outcome, so it should be appropriate for many parts of the world. The guidelines are built on evidence. And we received a lot of questions. And when I look into the question, we will discuss later after our first introductory talk. If I look at the questions go beyond the label and also by the authorities, the granting of the label. So actually guidelines are built on evidence. And we will discuss also how we can use the new information in our patients with diabetic kidney disease. We have today with us, and I'm personally very happy to have with us as a speaker, Professor Ian de Boer. Professor de Boer is Professor of Medicine and nephrologist at the University of Washington in Seattle. He also holds a degree in epidemiology and is adjunct professor of epidemiology at the University of Washington State. So actually, Professor de Boer is the chair of the KDIGO guidelines, the architect, and who has, I think, is the best person worldwide who can give us insights into the wide spectrum of the diabetes management in CKD. I'm also very, very happy that later on, as a discussant, we have Professor Katherine Tuttle. She is Professor of Medicine at the University of Washington at Spokane, Washington State again. She is a world authority as well in diabetes. I would say she's a nephrologist, but I think we all can call us also diabetologists meanwhile over time. And I will maybe introduce her again and she will comment the guideline. So consider this as an acceptance of these beautiful guideline, KDIGO guidelines by ERA-EDTA. Usually we endorse these guidelines. We are a little bit late, maybe over Christmas, but I think I consider this prominent e-seminars today as a type of endorsement. And I am happy to hand over to Ian de Boer. He will now begin his talk. And Ian, please, the floor is yours.
Thank you very much, Dr. Wanner. It's really a pleasure and honor to speak to the ERA-EDTA group here about the KDIGO guidelines and specifically the pharmacologic management of diabetic kidney disease. See if I can share my screen here. Can you see my screen now, Dr. Wanner?
Perfect.
Excellent. I do have disclosures here, including consulting for some of the companies that have made drugs that I'll talk about today, both SGLT2 inhibitors and GLP-1 receptor agonists. And I'd like to start by acknowledging all of the participants in the KDIGO work group that made the guideline I'll discuss today. This is a very diverse group in terms of specialty. It includes nephrology, endocrinology, cardiology, primary care, endocrinology, nutrition, pharmacology, It has worldwide scope, as Christoph already mentioned, and really deep experience. There are also 2 patients included in the working group, which kept the group focused on relevant questions, and it was supported by an evidence review team. Importantly, you'll note that both Dr. Tuttle, who Dr. Wanner introduced, and Dr. Wanner himself were critical members of the work group. So very briefly, when we set out almost 3 years ago now to create the first KDIGO guideline on diabetes and chronic kidney disease, we established some goals listed here. First and foremost was to generate a useful resource for clinicians and patients that addressed relevant questions with actionable recommendations, took on controversial topics when possible, and communicated clearly. Very importantly, we wanted to stay true to evidence, particularly from randomized controlled trials, and target the broad audience of clinicians who takes care of people with diabetes and chronic kidney disease. We were mindful for implications on policy and payment and proposed research questions. There's still much more to learn in this field, of course, but I won't focus on that too much today. We were supported by an evidence review team, the Cochrane Group in Australia, who performed systematic reviews and meta-analysis of all of the questions that we addressed. They helped us grade the level of evidence using the grade criteria, which you'll see in some of the recommendations I'll show today. The guideline is organized into 5 chapters shown here: comprehensive care, glycemic monitoring and targets, lifestyle interventions, anti-hyperglycemic therapies for type 2 diabetes, and approaches to management, including self-management and systems care. And for the sake of time today, I'll largely focus on number 4, given the title of the talk and what I was asked to cover. However, pharmacologic therapy on its own is, of course, not enough. And I will go over some of the recommendations for chapters 1 through 3 and also a slide on 5. Comprehensive care is diagrammed here in this pyramid on the right, and this is our conceptual model for treating people with diabetes and chronic kidney disease, who, as you all know, are at high risk of kidney failure, cardiovascular disease, and other adverse outcomes. Everything, of course, rests on lifestyle management, exercise, nutrition, smoking cessation, risk factor control, including glycemia, blood pressure control, and lipid management. That's a critical foundation for all of our care. On top of that, pharmacologic therapy is expanding, and you can see RAS blockade, which has been a foundation of care for decades now. To that, for most patients with type 2 diabetes and kidney disease, SGLT2 inhibitors are assuming an important role, and antiplatelet therapies for the patients who have established atherosclerotic cardiovascular disease. So this is an overview of comprehensive care. I won't go into all aspects of this pyramid in detail today. I'll focus largely on the pharmacologic therapy, for which there were many good questions submitted before the seminar and many actionable questions to be discussed. One aspect of comprehensive care is, of course, RAS inhibition. And I do want to point out a strong recommendation for an ACE inhibitor or an ARB, not both, of course, for patients with type 1 or 2 diabetes who have hypertension and albuminuria. That's a urine albumin to creatinine ratio of 30 milligrams per gram or more. And that these medications should be used at the highest approved dose that is tolerated. There are, of course, issues with management of hyperkalemia and increases in serum creatinine, which this audience is well aware of. And the guideline does go through some aspects of management, including hyperkalemia management, which does not have enough high quality evidence for recommendations, but which was addressed through practice points, which are in the guideline opinion-based instructions to help implement guidelines such as this one. I'll comment briefly on glycemic monitoring, and this is perhaps an expected recommendation. We do say that glycemia should be monitored in our patients with diabetes and CKD with hemoglobin A1C. Why is it even necessary to make a comment on this? Well, we know, of course, that particularly in kidney failure, where there's high red blood cell turnover with ESA treatment, that hemoglobin A1C can be biased. So our evidence review team did perform a systematic review of observational data looking at the performance of hemoglobin A1C and finding that it actually did quite well, at least down to an eGFR of 30 mils per minute and probably below that. In kidney failure, there is a concern that there's a bias to the low and imprecision, and we made some recommendations to consider measuring actual blood glucose using self-monitor blood glucose or continuous glucose monitoring when hemoglobin A1C did not seem to be performing well. But in general, hemoglobin A1C remains the treatment monitor of choice, and there is no advantage to alternative markers known, such as glycated albumin or fructosamine. What should we be targeting for hemoglobin A1C levels in patients with diabetes and chronic kidney disease? Well, as the ADA and EASD recommend, we recommended an individualized approach to generating hemoglobin A1C targets. Patients who had more complicated disease on the right with more complications, comorbidities, short life expectancy, and high risk of hypoglycemia should have higher hemoglobin A1C targets, such as less than 8%. Patients with fewer comorbidities and complications could have lower goals, including goals as low as 6.5%, which was questioned by some, but in 2021 is more readily attainable with glucose-lowering medications that do not cause hypoglycemia, and also with continuous glucose monitoring as an adjunct to help achieve lower blood glucose levels without hypoglycemia. So the goals should be individualized according to these characteristics. I'll show several slides summarizing lifestyle recommendations. The first slide is a practice point, making the statement that in general, I'll paraphrase this as saying patients with diabetes and chronic kidney disease should consume a heart-healthy diet. Our patients receive so many messages about what they should and particularly what they should not eat that we thought it was important to start with what they should and emphasize that balanced heart-healthy diets are appropriate. Now, of course, these need to be individualized and moderated. People have hyperkalemia or other indications to moderate specific foods that can be added. But that's not actually the majority of patients with diabetes and chronic kidney disease. And I think the first message needs to be increase consumption of vegetables, fruits, whole grains, fiber, legumes, etc., and focus more on what can be eaten than cannot. Dietary protein intake has been something we've considered in nephrology for quite some time. The World Health Organization recommends a dietary protein intake of 0.8 grams of protein per kilogram per day in general for people. We reviewed literature looking at lower protein diets and did not find high quality evidence that reduced CKD progression. There were observational data suggesting that high protein diets could be harmful, and therefore we recommended that the standard protein intake of 0.8 grams per kilogram per day was appropriate for most patients with diabetes and CKD. Our dialysis patients, particularly our peritoneal dialysis patients, do need slightly higher protein intakes to offset catabolism and protein losses. We also recommended, as possible, targeting a sodium intake of less than 2 grams per day, consistent with many recommendations outside of nephrology to reduce risk of cardiovascular disease and help control hypertension. So now I'm going to focus more extensively on pharmacologic therapy. And in type 1 diabetes, of course, pharmacologic therapy is based on insulin, and I'm not going to cover that in detail today. What I will focus on is pharmacologic therapy in type 2 diabetes, for which the drugs available have expanded and the data evaluating those drugs have exploded. And this is a graph showing by color-coded by class of medication, the trials that have come out over the last 8 years, evaluating the clinical outcomes of new glucose-lowering drugs for people with type 2 diabetes. This is all based on requirements from the FDA and EMA in 2008 that new glucose-lowering drugs have cardiovascular safety trials. and this has provided us a wealth of new information. And I'm going to start focusing on SGLT2 inhibitor trials. And we now have 10 published large clinical outcomes trials of SGLT2 inhibitors. And I've organized them in three categories here. In blue are the cardiovascular outcomes trials. They're generally conducted in people with type 2 diabetes and high cardiovascular risk, and they evaluate primary MACE outcomes. That's major atherosclerotic cardiovascular events, such as myocardial infarction and stroke. We also are fortunate to have in green chronic kidney disease specific trials. These are trials that have enrolled CKD populations and evaluated CKD outcomes, particularly for CREDENCE and DAPA-CKD. Scored here of sotagliflozin enrolled a CKD population and actually looked at a primary cardiovascular outcome. And then in yellow or orange here, there are also SGLT2 inhibitor trials focused on heart failure populations that evaluate heart failure outcomes. And what have these trials shown? Well, here is a nice meta-analysis of the 4 cardiovascular outcome trials plus CREDENCE. And I think this provides the most precise estimates of what we should expect for effects of SGLT2 inhibitors in general. On the upper left, you can see that major atherosclerotic cardiovascular outcomes are reduced on average by about 10%. Cardiovascular death by 15%, hospitalizations for heart failure by 32%, and CKD progression defined by some increase in creatinine, varies across trials, or kidney failure reduced by 38%. You can see that these are fairly consistent. These appear to be class effects, and that on the right, the heart failure and CKD outcomes are the ones that are really, in terms of magnitude, improved most dramatically. We're fortunate, of course, to have the CREDENCE trial evaluating kidney disease patients with a primary kidney outcome. This was published in the end of 2019 and briefly summarized in this visual abstract. It included over 4,000 people with type 2 diabetes and albuminuria. That's a urine ACR of 300 milligrams per gram or more, and an average eGFR of 57, randomly assigned to canagliflozin or placebo. The primary outcome was doubling of serum creatinine, end-stage kidney disease, or death due to cardiovascular kidney disease, reduced by 30% with an impressive number needed to treat of 21, and also a significant reduction in end-stage kidney disease. No differences in amputations and fractures, and I'll comment on adverse effects later. DAPA-CKD was published just last fall and included 2/3 a population with type 2 diabetes and 1/3 without. I'll get to that on the next slide. All defined by albuminuria with a urine ACR of 200 milligrams per gram or more. Also a primary kidney disease outcome. The trial was stopped early for benefit with an estimated risk reduction of 39%, highly statistically significant. Also significant reductions in end-stage kidney disease, hospitalization for heart failure, and all-cause mortality, with a cardiovascular death reduction that was not significant but consistent in magnitude with the other studies I noted. And of course, with DAPA-CKD, one of the most interesting findings was that while the 1/3 of participants without diabetes had fewer events and a lower event rate than those with type 2 diabetes, the relative risk reduction, the hazard ratio with dapagliflozin compared with placebo was at least as impressive as in the type 2 diabetes population. This is the first clear signal that SGLT2 inhibitors may have important benefits outside the type 2 diabetes population. And we hope to get more data in this population with the Amputations trial and other trials in the future. So looking across all these trials, we really have covered the heat map of kidney function, and the early CVOTs have enrolled people with eGFRs of 30 or more in all ranges of albuminuria, mainly in the normal or moderately increased range. CREDENCE gave us very high quality data on SGLT2 inhibitors in the severely increased albuminuria range. DAPA-CKD also covered that range, extending the albuminuria down to 200 milligrams per gram. And very importantly, I failed to note earlier, used an inclusion criteria down to 25 mils per minute for the first time. Others had been limited at 30. Soon we'll see results from EMPA-KIDNEY, which includes more participants with normal albuminuria and eGFRs down to 20. Very importantly, when looking at participants across this heat map, the effects of SGLT2 inhibitors are consistent by baseline albuminuria and also by baseline eGFR, with significant reductions in cardiovascular and kidney outcomes in all albuminuria and kidney outcomes. What about adverse effects? These are oftentimes what limit implementation. These are in general quite safe medications. The most common adverse effect is attributable to the medication is genital mycotic infection, which has an attributable risk of 4 to 5% overall, more in women than men. These are generally treatable. The 48 gangrene has been reported. Hypoglycemia is variably increased or similar across the trials. Overall, in meta-analysis, hypoglycemia is slightly increased and seems to be, most importantly, restricted to people with insulin or sulfonylurea concomitant use. Volume-related adverse events due to natriuresis are actually quite uncommon and in some trials not increased, in some trials modestly increased compared to placebo. And interestingly, one might expect acute kidney injury to result from that, but in fact, a meta-analysis of studies not looking at AKI as a primary outcome, and this is ascertained through adverse events reporting, but it suggests that AKI is reduced by 25% compared to placebo. So actually a safety signal, not for benefit, not for harm. And I'll touch base quickly on the mechanism shortly. Other adverse events that have been brought up is the possibility of amputation, and the Canvas trial first saw a higher risk of amputation with canagliflozin compared with placebo, a risk ratio of 2.2. However, notable here, other SGLT2 inhibitor trials have not seen the same signal, including CREDENCE, which prospectively ascertained amputations using a specific protocol. So more data are needed here. It's not clear whether amputations are a class effect, a canagliflozin effect, or just an anomalous signal here. And we'll continue to monitor in the future. So overall, the KDIGO work group felt that the benefits, which I've summarized here on the left, were quite strongly outweighing the risks of SGLT2 inhibitors, and you'll see they placed SGLT2 inhibitors quite prominently in the treatment algorithm for type 2 diabetes. What about GLP-1 receptor agonists? We also have great data there, and I'll spend a little less time here, but this is a meta-analysis performed by the KDIGO group looking at major adverse cardiovascular events and stratified by chronic kidney disease stage, normal eGFR on the top and lower on the bottom. And what's seen here is that GLP-1 receptor agonists do reduce major atherosclerotic cardiovascular events with no effect modification by eGFR. So there's good, high-quality evidence that these have atherosclerotic cardiovascular disease protection, including in chronic kidney disease. And in fact, that seems to extend to mortality reduction as well. And you'll see that KDIGO makes a recommendation for GLP-1 receptors based on these evidence. What about GLP-1 receptor agonists and CKD progression? The jury is still out here in my mind. These are data from the LEADER trial of liraglutide. And on the left is the cumulative incidence of a composite outcome that included eGFR loss, ESKD, and macroalbuminuria. And you can see that liraglutide reduced the risk of this composite outcome by 22%. That was driven largely by macroalbuminuria, and that's been seen in other GLP-1 receptor agonist trials as well, that albuminuria reduction is fairly consistent. In LEADER, there was no significant difference in the change in eGFR or eGFR loss outcomes, though in a subgroup analysis, people who started with low eGFR, 30 to 59 mils per minute, had a slower loss of eGFR compared to placebo. And that was an initial hypothesis generating finding. And there are more data suggesting that this signal may be true. This is a study, Award 7, led by Dr. Kathy Tuttle, which used an active comparator design. So these were patients with type 2 diabetes and stage 3 and 4 CKD, eGFRs of 15 to 59, who were assigned to DULAGLUTIDE, a GLP-1 receptor agonist, and aspart insulin, or to long-acting glargine insulin plus aspart insulin. And it was a shorter term study. You can see these are 1-year data here, but there was a dose-dependent benefit of dulaglutide on eGFR loss, looking at slope on the left, the summary loss over the year shown here in the center, and then in a secondary analysis, also dose-dependent benefit, the relatively small numbers of events on a composite outcome of eGFR decline greater than 40% or ESKD. That was just published, I think last month. So accumulating data that GLP-1 receptor agonists may have kidney benefits, probably not as great as SGLT2 inhibitors. The FLOW trial of semaglutide will provide us, I think, the next information on these kidney outcomes in people with kidney disease. So this is a summary of trial data included in the KDIGO guideline. And in this summary, the down arrows, one down arrow means a significant reduction of 1 to 29% magnitude, and 2 down arrows means significant reduction of 30% or more magnitude. And so you can see that SGLT2 inhibitors, while having relatively weak effects on glycemia, particularly as eGFR drops, and inconsistent, though, on meta-analysis, small effects on major atherosclerotic events. They have large effects on heart failure, albuminuria, and GFR loss reduction. GLP-1 receptor agonists have shown in some studies reductions in major atherosclerotic cardiovascular events, and the meta-analysis suggests overall there is such an effect. They have albuminuria lowering and perhaps also effects preserving GFR. DPP-4 inhibitors, which I haven't discussed, are modest at lowering glycemia. They're safe. They lower albuminuria, but studies have shown no effect on GFR. And so they have assumed a less prominent role in the KDIGO guideline. So this is how KDIGO is put together, the treatment algorithm for selecting anti-hyperglycemic drugs for patients with type 2 diabetes and chronic kidney disease. And as I mentioned earlier, therapy should always be based on appropriate lifestyle, physical activity, nutrition, and where appropriate, weight loss. But what KDIGO has recommended is that SGLT2 inhibitors be placed as first-line therapy for type 2 diabetes, along with metformin when eGFR is greater than 30. So there's a lot of information in that statement, and I'll explain a little bit more. Perhaps I'll start with metformin. Metformin is an inexpensive, safe, and effective drug for glucose control. In the trials I mentioned, many, though not all, patients were treated with metformin when other glucose-lowering drugs were added. And so the work group felt that it was appropriate to continue metformin as a foundational therapy for type 2 diabetes. It does need to be dosed according to eGFR for the risk of lactic acidosis. And so these are our reductions, reducing metformin dose at less than 45 mils per minute, discontinuing at less than 30, or treatment for dialysis. SGLT2 inhibitors, I've mentioned eGFR thresholds to some extent. Until DAPA-CKD, none of the large trials had an eGFR threshold for eligibility that was lower than 30. So it was quite clear that if your eGFR is 30 or more, that you would be included in the evidence for SGLT2 inhibitors, and that's what we recommended for initiation. Now, as opposed to metformin, where the eGFR threshold relates to safety, that's lactic acidosis, The EGFR threshold for SGLT2 inhibitor is not thought to relate to safety. In fact, with use at lower EGFRs, they're less effective for glucose control. Not necessarily less effective for kidney progression or cardiovascular outcomes. And as I mentioned, DAPA-CKD has pushed this EGFR threshold to 25, and Empankidney is going down to 20. So this threshold may change over time, but I think in January of 2021, still based on the accumulated evidence, we should be targeting people who have type 2 diabetes and in EGFR of 30 or more for initiation of an SGLT2 inhibitor. Now, what happens if you initiate somebody and they fall below 30? Well, the CREDENCE and DAPA-CKD protocols both included continuing that medication at least until dialysis. And so the KDIGO guidelines recommend following that lead and continuing SGLT2 inhibitors after initiation at any EGFR as long as they're well tolerated. Shown in the bottom of this diagram then is what to do for people who do not have adequate glycemic control on metformin or SGLT2 inhibitor, or are unable to take one or both of those medications because of low EGFR or other adverse effects. And I'll show another slide on this momentarily. Note on the top that GLP-1 receptor agonists are the preferred next line agent because of their benefits for atherosclerotic cardiovascular disease and possibly kidney disease progression. There are lots of questions. In fact, you, the audience, have submitted lots of questions about the practical aspects of initiating and treating with SGLT2 inhibitors. And Sophia Zongas, who's another member of the working group, and I have attempted to address these in a paper, a perspective paper that will be coming out shortly in CJASN. This is the central figure from that, which attempts to provide practical provider guidance. And on the top row of this, you can see recommendations for patient selection. Again, EGFR of 30 or more, prioritizing people who have albuminuria and heart failure, who are most likely to derive highest benefit, though again, the recommendation applies to people with any sort of chronic kidney disease, albuminuria or low EGFR or both. There are some patients for whom treatment may be inappropriate. In my practice, it's people with high risk of genital infection. I have some patients with indwelling Foley catheters, for example, who have not started on SGLT2 inhibition. When starting an SGLT2 inhibitor, there does not seem to be dose-dependent effects on the kidney and cardiovascular benefits. So we recommend the lowest proven dose of agents that have been shown to have clinical benefits. Those are listed here. We do recommend educating on sick day protocols and perioperative care to reduce the risk of diabetic ketoacidosis, which in the type 2 diabetes population is low but real. And following up, though, with the knowledge that an EGFR drop is expected. More sticky are the issues of what to do with glycemia and volume control for tenuous patients, and our guidance is here. Most patients do not have high hypoglycemia risk, and no changes to concurrent hypoglycemia medications are needed. However, for patients treated with an insulinosulfonylurea who have a history of severe hypoglycemia and hemoglobin A1C is already low, it's worth warning patients about symptoms of hypoglycemia, considering reductions in insulin or sulfonylurea doses, and following up on hypoglycemia symptoms after initiation. Similarly, for volume, most patients, again, do not have problems. In fact, most of my patients need a little bit of extra volume control, and the natriuresis with SGLT2 inhibitors is welcome. However, patients who are very tenuous, for example, those with heart failure with reduced ejection fraction, concurrent diuretic use, and a history of AKI, if there is high risk of volume depletion, can be considered to adjust concurrent diuretic doses, and most importantly, follow up on volume to see whether additional changes are needed after initiating an SGLT2 inhibitor. For those patients who are not controlled on an SGLT2 inhibitor and metformin or can't take these, we've made this diagram to help guide selection of additional glucose-lowering agents. Again, in general, GLP-1 receptor agonists are preferred. The way this diagram works is it starts with patient characteristics in the center, their preferences, comorbidities, and other characteristics. For example, if a patient has a high hemoglobin A1C and their priority is potent glucose lowering agents, the green and red circles show the more appropriate and less appropriate additional agents to treat. More appropriate in this case would be a GLP-1 receptor agonist or insulin. Less appropriate might be a DPP-4 inhibitor, thiazolidinedione, or alpha-glucosidase inhibitor. The KDIGO guideline does make recommendations for structured self-management for people with diabetes and CKD. Their involvement in care is critical to improve knowledge, beliefs, and skills related to management, increase motivation and adoption of healthy lifestyles. We also have instructions to, because of the complex care of these patients, put systems in place to identify and adequately treat people with diabetes and CKD. I'll make a couple comments on the future before we open for questions. And one is, it's fabulous here, first of all, that we've had, in addition to RAS inhibitors, SGLT2 inhibitors and GLP-1 receptor agonists added to our armamentarium. And more drugs seem to be coming. So most of you are aware of the FIDELIO-DKD trial just published at the end of last year, which was a double-blind trial of finerenone, a mineralocorticoid receptor antagonist, versus placebo in people with type 2 diabetes and chronic kidney disease. And finerenone versus placebo reduced the primary outcome of kidney disease progression by 18% and the secondary outcome of cardiovascular events by 14%. These are significant and important, but not as large as we've seen with SGLT2 inhibitors. They're more similar to RAS inhibitors. They were on top of RAS inhibitors, though only a minority, I think about 4% of participants were treated with SGLT2 inhibitors. So the combination is still unknown, but this does seem to be another drug that may help improve outcomes in people with type 2 diabetes and diabetic kidney disease. How to fit it in the algorithm remains not clear. And there is another finerenone trial in progress that will have cardiovascular and kidney outcomes that may help clarify that. There's also the SONAR trial, which was published in the end of 2019, looking at atrasentan versus placebo. It had a sophisticated selection design, including responders, and it was stopped early by its sponsor due to low event rates. But when the events that occurred were added up, it turns out that the primary outcome of kidney failure was reduced significantly by atrasentan compared by placebo, as were cardiovascular events. So this was the first trial suggesting that endothelin antagonists may also have clinical benefits among people with type 2 diabetes and chronic kidney disease. And again, shows that we may be having going from a situation where we only have RAS inhibitors as our only real treatment option to having a menu of treatments that we can prescribe for type 2 diabetes and chronic kidney disease. So how are we going to do that? Well, there are a number of options. We could start layering multiple medications on top of each other. The cardiologists do this all the time. That might be the right approach to doing things. So many of these medications, as you've seen, have hemodynamic effects to lower intraglomerular pressure. It's not entirely clear how much of that any individual patient can tolerate. Another approach is to try and target appropriate therapies to appropriate patients, a precision medicine approach. And I'd just like to introduce one study, the Kidney Precision Medicine Project, which is sponsored by the NIH here in the United States, that is hoping to support that goal. This is a new cohort study of people who get a research kidney biopsy. Is targeting populations that normally do not have kidney biopsies, including people with diabetes and chronic kidney disease, also people with hypertension and chronic kidney disease, or hospitalized acute kidney injury. And for these people, collecting deep clinical phenotyping, pathology, omics, that's transcriptomics, metabolomics, and proteomics in the kidney tissue and clinical outcomes, with the goals of creating a reference kidney tissue atlas for science of all sorts, developing mechanism-based disease subtypes that may help guide specific therapies to specific patients, and also identifying critical cells, pathways, and targets for novel therapies, helping to develop even more drugs to treat this high-risk population of patients. All right, so I'll summarize here regarding the KDIGO guidance for diabetes and CKD management. This is the first guideline on diabetes and CKD from KDIGO. I think it comes at an opportune time. It provides recommendations across a variety of diabetes and CKD care topics. It advocates patient-centered decision-making and support, including lifestyle modifications as a foundation of management, risk factor control, including RAS blockade, appropriate glycemic care with hemoglobin A1C, monitoring and individualization of targets and therapies. Importantly, for type 2 diabetes, first-line therapy with both metformin and an SGLT2 inhibitor, and coordination of efforts to implement this work. And I'd like to stop by acknowledging the members of the KDIGO work group, including our moderator, Dr. Wanner, and our discussant, Dr. Tuttle, as well as the KDIGO staff and organization and the evidence review team that helped with this guidance. And I hope that we have some time for discussion.
Yes, thank you, Ian. You covered a lot. Actually, most of all essential information in the guidelines. And actually, you showed us also a slide from Chef Alou in Diabetes Care about the exploding evidence. And it's difficult to cover this all. And I want to now go over and ask our discussant, Katherine Tuttle. Katherine, welcome. I introduced you initially as a professor of medicine, as a nephrology at the University of Washington at Spokane, and one of the members of our work group and a worldwide expert. And I also told that you are nearly a diabetologist with all your research. So the first question I would like to hear your comment about this, and maybe the first question, because of this exploding knowledge and the new trials Ian already covered, actually, which are already in the questions which we received from participants. What do you think is missing in the guidelines? What we have to rewrite soon? And or how do you feel about current status of guidelines 4 months later?
Well, thank you very much, Professor Wanner, and it's wonderful to join you today. And thank you, Professor de Boer, for that overview that really hit the highlights. But as Professor Wanner said, this field is moving so quickly that the guidelines are almost going to need to be updated very soon. Professor de Boer talked about, for example, the FIDELIO trial that published after the guidelines were completed, and then Figaro, which will report out probably sometime this year. So I think one of the exciting challenges in our field is, after a long period of stagnation, we do now have a number of therapies coming forward, and it will be time to review the new evidence. And I think the challenge is that these studies were conducted in parallel, and we're going to have to learn how to apply them in the context not only of renin-angiotensin system inhibitors, because the new therapies were studied on top of either an ACE inhibitor or an ARB, but what do we do about SGLT2 versus finerenone? When do we combine therapies? And I think, you know, of course, those will be the topics of future research. But in the meantime, I think experts will need to convene to think about, based on the available evidence, how are we going to prioritize treatments, and how are we going to select the right patient for the right treatment, especially before those sorts of studies are done. So these are challenges, but I would say they are good challenges to have, because we spent many, many years without any new therapies. So it is going to be something that our field will need to address, but I would say it's a pleasant challenge.
for people in the field, there is so much excitement, and actually they cannot wait. And you are talking about we have to review and digest, and I would say I cannot wait until you can apply these medicines. What is the inertia currently, what people still think how long it takes that we can really take it up and prevent dialysis?
So, that is really, I think, the most urgent question, because if we look at data from real world clinical practices, even though we have known about ACE inhibitors and ARB for the treatment of diabetic kidney disease and other forms of CKD, the uptake in clinical practice is actually very low and very slow. I could speak for the United States, and depending on the health system that's studied, the rates of use of these agents among patients with CKD who have an indication, either proteinuria, diabetes, most of us would agree those patients should be on treatment. Only 20 to 40% of patients are actually receiving them. So now a major challenge is really beyond the evidence and beyond guidelines to implementation. And I would say in the field of nephrology, we have not focused on dissemination and implementation science. And maybe you could say, well, we didn't have enough to work with, but even with ACEs or ARBs, we're really underutilizing them. And even outside the US, at least to the extent I'm aware, and I'd be interested in your reflections on this, Professor Wanner, but even in other regions of the world, the uptake is far from optimal. So in order to deliver on the promise of the new therapies, we need to really now focus on dissemination and implementation, and to really, if you will, get the house in order and to get patients on an ACE inhibitor or an ARB as the foundation, because really the new therapies that we're talking about, we're studying in combination with those agents, and to figure out how to get the job done. Because if we're 20 years into ACE inhibitor and ARB evidence, and we still have utilization less than half the patients who we think would benefit, then I think that's really the big gap.
When I recall your paper in JAMA, you were also discussing identification is in the low range, especially when you want to identify DKD with UACR or any albuminuria test. Tell me more about this, how this is currently in the United States, or how it was in your paper.
Yes, so thank you very much, Professor Wanner. I think, again, this is a major issue, is identification of chronic kidney disease. The awareness and detection is very low in community practices. And, we can speculate on the reasons why, but in fact, that really hasn't even been studied. But there have been some surveys done in the US of awareness, even among professionals, among doctors. Awareness of kidney disease and diabetes is quite low. Less than half of the primary care providers are even aware of the fact that their patients have kidney disease, and patients with diabetes are, less than 20% or so are even know that kidney disease could be a complication. So there's a big educational piece that needs to be done, because at the point where awareness and detection will make a difference on intervention, most of these patients are in primary care practices. So in order to get people treated, we have to improve awareness and detection. I think it involves education, but it also involves, I think, priorities within healthcare systems. And to be honest with you, kidney disease has not been a high priority in US healthcare systems. The focus has been elsewhere. And so that gets to another point about, I would say, advocacy and patient activation in other fields where there's been greater awareness and focus, such as cancer or cardiovascular disease. We've seen much more activity around patient activation and education of the professional community in response to that. So I'm interested too in Europe, what the observations are, how well you're doing there in terms of awareness and detection, which really is the foundation upon which we start start treating patients.
Just to respond quickly, nephrologists in Europe, they feel that they are quite good and they meet the KDIGO heat map. A general practitioner is a huge problem, and
right.
But this has several barriers. And I think we have to implement the two components of the kidney test into healthcare systems also,
right.
that they're adequately reimbursed and so. So and at the end, I think we are not better than what you have shown us from the US. Yeah.
Well, I think the point is that most of these patients are in primary care. And yes, and I would say in the US, by the time nephrologists see them, they're more likely than not going to be tested and treated appropriately. But the vast majority of people at risk are with early stages of kidney disease, when many of the treatments will work best are in primary care, and that is a real barrier.
So Ian, you may have seen the question in the chat, and this is exactly what usually nephrologists not see, but this is high eGFR, but already albuminuria. And is this a patient appropriate for SGLT2 early on? And the same,
absolutely.
Then there is also,
yeah. So we focus on the more advanced patients that we see who have high risks of kidney disease progression and can benefit largely from SGLT2 inhibitors and GLP-1 receptor agonists. But in terms of population-wide, the greatest benefit of these drugs will come by initiating them earlier in the course of diabetes. As you've been discussing, that's largely in primary care here. But yes, patients with normal GFR and albuminuria, according to our guideline, would be recommended to have an SGLT2 inhibitor as part of the regimen. Those who have no evidence of kidney disease would also benefit in terms of CKD prevention. We've seen that in the trials as well. Those patients have lower absolute risk of developing kidney failure, and so they have other potential goals, and per ADA and EASD recommendations, a broader range of choices for their drugs, but SGLT2 inhibitor is definitely one of them.
Both of you have not talked, no, Ian actually had talked about safety, but safety is still an issue in the real world. But it's fading away in the latest randomized controlled trials where, for example, genital infections are declining from early on 1 out of 10, now in 2 out of 100. Could you comment on this? Do you understand this? Are we better now with hygiene, or why is this going away?
Well, Professor Wanner, I do think it's a hygienic issue, and there's actually been a study done in patients with type 2 diabetes who simply were randomized to receive specific instructions on hygiene and daily bathing and clean clothes, and that intervention alone reduced the risk of genital yeast infections by 50%. And I think now practitioners have become aware of that and are mentioning it and focusing on it, and it becomes a manageable situation with a very simple intervention, which is a discussion and guidance to the patients. So yes, I think we're learning how to manage the safety issues, and they should not be a major barrier to use of these agents.
Ian, do you agree?
I absolutely agree. It is an interesting trend. I think that's the only explanation that I can see as well. You have to understand and acknowledge the problem to prevent it. And I think more broadly, I spent a few slides talking about the adverse effects and a slide on how we can easily mitigate them. Their SGLT2 inhibitors are quite safe drugs. I think that the steps needed to take to reduce the minimal risks are pretty straightforward and are ones that are easily done by nephrologists and lots of other providers. These are not drugs that need endocrinologists to be prescribed. We should be prescribing them, as should primary care doctors.
Then I have a question here. I think when the incoming president of the ISN is asking a question, we should respect this. And she feels that we should give a short education about the mechanism of action in non-diabetic kidney disease. Most people may not have understood it. Who wants to give a short explanation?
Well, I could start on that, I suppose. I thought I had a slide in the presentation about mechanism, and I must have taken it out to leave time for this discussion. This is a very interesting situation in which these effects, beneficial effects of SGLT2 inhibitors on the kidneys were much greater than anyone would have expected. So now we're going in reverse of what we usually do. We've seen this clinical finding and we're trying to understand the mechanism. And I don't think we fully understand it. There are some things we know. Of course, with natriuresis, there's blood pressure and weight reductions. Those are beneficial, but certainly can't explain these effects. There clearly is a hemodynamic component through which, by blocking proximal sodium and glucose reabsorption, there's more delivery of sodium to the distal tubule macula densa, restoring tubulo-glomerular feedback, constricting the afferent arteriole and lowering our glomerular pressure. And that probably is at play both in diabetes and in non-diabetic patients. However, you would hypothesize that that mechanism would be greater in people with diabetes who normally have greater proximal glucose and sodium reabsorption. I think there are other aspects as well. I do think that there are probably hypoxia and workload effects of the proximal tubule. You consider these drugs to be beta blockers of the kidney by reducing the rather large workload of reabsorbing glucose and sodium in the proximal tubule. Maybe that's contributing to the beneficial effects of AKI as well. And I think there are much greater metabolic effects in the proximal tubular cells than we've described to date. On fuel metabolism, autophagy, and repair processes. And I think there's a lot of research that needs to be done there. Kathy, I don't know if you want to add.
Yeah, I think you've covered it really well. There are also putative anti-inflammatory effects as well. And like you said, I think it's really an exciting time where the clinical observations are driving the science to try to unravel this. And as you've said, I think the strongest signal is for a hemodynamic effect. And I think it harkens back to what a dominant role hemodynamics play in progression, no matter what the inciting cause of the original injury may have been. But I agree with you, there are likely to be pleiotropic effects. And it is important that we do unravel those mechanisms, because that'll help us more with the precision approach that you talked about of targeting right treatment, right patient, right time, because we know that mechanisms do change and evolve over the course of disease. And there is going to be a limit to how many drugs we can layer on. And again, a sobering sort of centering point back to clinical practice. I'll be going to clinic right after this meeting this morning, and the average number of problems on the problem list is 10 to 20, and you can then multiply the number of drugs by 1.5. In fact, I did that in clinic last week. I didn't see anybody on less than 15 medicines. How many more can you add on for one particular condition? And so I think that the other big challenge, this is circling back to Professor Wanner's question about how are we going to use these agents in implementation. I think if we can get to precision approaches, we might not need 3 or 4 drugs for individual patients. We may be able to get down to fewer medicines, which will reduce cost, complexity, and side effects, because it is really challenging for patients to manage all of this on top of everything else they're dealing with. So that's where mechanisms are important, because if we understand the mechanisms, then we are able to target therapies and perhaps not have to use so many in every patient.
I have a patient for you, Kathy, which is a type 2 diabetic with an EGFR of 38, and you want to start an SGLT2 inhibitor. Do you still measure hemoglobin A1C?
Yes, glycemic control is still going to be important. Now, these agents have less glucose lowering effect as GFR is lower, even though the kidney protective effects are preserved. However, if they're on an insulin or an insulin secretagogue, they can develop hypoglycemia. So I think it is important to monitor glycemia. And actually, even in lower GFR patients, it may be more important to do self-management or self-monitoring of blood glucose or CGM, because the A1C may not be as accurate. but we need to watch for hypoglycemia, and we may have to reduce other glucose lowering agents in order to give the SGLT2. The one thing I would caution about in terms of safety, for the patients who are on insulin, remember insulin is the best defense against ketoacidosis. In that case, you may go with a lower dose of an SGLT2 in order to preserve the insulin, because as far as we know, the SGLT2 benefits on the kidney appear to be dose independent. So even low dose SGLT2 is kidney protective, but one has to be cautious about adding it on top of insulin or insulin secretagogues because of risk of hypoglycemia. But like Dr. Boer said, nephrologists can do this. We just have to have a culture shift, but we do much more complicated things. So don't be put off by the management of glucose. It just requires to be intentional and thoughtful and careful monitoring of the patient.
Ian, do we still talk about SGLT1 inhibitors in the future?
Well, most of these drugs do have some SGLT1 effect, and it's interesting. There's a range of selectivity for SGLT2 versus 1, but all the drugs as a class do seem to have these kidney and cardiovascular benefits, and it seems to be a secondary issue to me about the SGLT1 part of the drug. I would like to comment also that I'm seeing in the chat lots of good questions, a lot of them pertaining to populations. Who should we be targeting? And including non-diabetic patients. There are excellent questions about what about transplant patients, even dialysis patients. They're all great questions, and I hope that the populations that we're treating with these drugs will expand over time. But I want to get back to the thing that the concept that Kathy mentioned, which is implementation first in improving populations. We now have 10 trials of SGLT2 inhibitors in people with type 2 diabetes demonstrating the benefits that we've talked about today, and lots of patients who are not getting those drugs. So we need to start by finding and prescribing to and implementing in the populations who we know today are going to benefit, and hopefully expand in the future. But we have work to do there first.
So maybe just, we are going over the hour, but there are so many questions, and just one is confusing for the audience. What Ian was saying, does this apply also to nephrotic syndrome versus non-albuminuric patient? That's two edges of. Kathy, or do you want to say something?
Well, I think the available data from DAPA-CKD showed that in non-diabetic patients who have a UACR between 200 and 5,000 milligram per gram, there was clearly benefit. And it was irregardless of cause, although the majority of patients, non-diabetic patients in DAPA-CKD had IgA or FSGS. But I would think that that is pointing certainly in the direction that those patients benefit. And then with regard to normal albuminuric patients, Professor De Boer addressed this as well. If you look in the KDIGO guideline, we don't have a requirement for albuminuria. And that is because if you look at the cardiovascular outcome trials in type 2 diabetes, there's clearly cardiovascular protection irrespective of albuminuria. And remember that is, to be honest with you, that's the more common risk even in patients with CKD, is death outcompetes progression at least 2 to 1, and death rates increase as GFR drops. So we need to be focusing on the outcomes in patients, not the totality of outcomes, the most important of which is death. And among the living, avoiding the complications that lead to death, such as cardiovascular events, because you only live to get you only have kidney failure if you're alive. So the indication, if we think of the totality of the patient, is to preserve life, and among the living to stay well, and that's having fewer cardiovascular events and progression of kidney failure. So in the non-albuminuric patient, we certainly care about kidney function, but the cardiovascular outcome trials clearly show that they save lives. So that's the reason we should be using them.
think this was nearly a statement at the end, and actually we come to the end. Maybe Ian, you can have a final statement, and before you do this, as the chair of the guidelines, I will anyway thank you very much. This was for me very exciting. Actually, we were walking on a very high level today. And Kathy, maybe if we do this next time, and you may say to me, Christoph Wanner or Dr. Wanner, you know that German professors want to be called always professor, and
That's
actually you picked up this habitude. But anyway, thank you both. And Ian, do you want to make a final comment?
Well, Professor Wanner, I would like to echo your enthusiasm, and I think it is very telling that your first question was, what do we need to change in the guideline now? And it's only been less than 3 months since it's been published. So this is a rapidly moving area. It is very exciting to have new therapies available for our patients. And I appreciate the ERA, EDTA, and both of you as moderators putting this on to talk about this rapidly evolving and important area. Thank you very much.
So thank you both, and I close the e-seminar. Thank you.